Good morning. I have Kirby Kraft with me today from Magee General Hospital. Kirby is the, let me get this correct now, the Chief Information Officer for the hospital. And I was so glad when Lori brought up that Kirby could come, because I've been real interested in how the hospital has changed with medical records.
Right.
And it's just almost 100% different than we had in the past. And I wanted you to explain to our audience a little bit about how medical records work now.
Okay. Well, the term EHR is an electronic health record, and electronic health record is basically just what it sounds like. It's a means of taking your folder that used to contain all of your papers that was part of your medical record and moving it into an electronic format so that it can be accessed electronically, which opens up the doors for a number of different capabilities.
Mm-hmm.
And so it's a direction that the government is leading us in, and it's a good direction.
When you do medical records, I know, I still think of charts and folders, like you say. Do you fill those out does the doctor fill them out in the room, those medical records on their computers? How does that work? Or are you transcribing?
Well, that's a good question, and it's a point of a lot of confusion. So let me talk briefly about the direction that we're headed with EHRs, and that is that there's actually an electronic health records philosophy that the government is moving us towards, and there's 3 stages of that. So we're in stage 1 right now, which is a computerized physician order entry. So the physicians right now can place orders in there. They can see the results of lab, x-rays, and things like that in the electronic health record. So at present, because we're in stage 1 of a 3-stage process, we're actually in a migratory portion of that. So right now within the hospital environment, it is a combination of the paper and the electronic health record. But we're charted to mandated to go to stage 2 in 2014. And we'll probably actually be doing that before then, just because we want to, which will include getting almost everything out of the paper chart into the electronic system at that point. So we're headed that way. Now the clinic systems and the hospital systems are a little bit different. In our clinic environment, they're just about paperless over there. And one of the reasons that there's difference between the 2 infrastructures is the hospital system is so much more complex, and on the surface you might not realize that, but there's so many compartments in a hospital that all these have to tie together to make the electronic health record work for a patient. Something, for example, that you might not even think about, like dietary, just the dietary needs of a patient, of a diabetic patient or something like that. So there's all these components in a hospital and in a clinic setting. Don't mean to oversimplify their system, but there's not as many towers in there for them to have to manage. So in the clinic system that we have, and it's a different kind of system, it's called Allscripts. We are primarily paperless over there for the clinics. But in the hospital system, and it's not unique for our hospital, all hospitals are like this. We're in this multi-stage effort to get to where we are completely paperless with the system.
Then it seems so strange, but I think it's a great thing. I mean, I think it's wonderful. Do you find that will we be able to, if I came into the emergency room, will my records be accessible? Are they accessible now, or will they be in the future, or how does that work?
Well, yes. Right now, one of the things that should be part of our discussion is HIPAA. But right now, HIPAA restricts that access, and so it's not that just every hospital has access to everyone's health records. Mm-hmm. But if you go to Magee Hospital and you've been to the hospital, all of your lab work, your X-rays, your MRIs, whatever you've had done previously is accessible right now in your electronic health record.
Well, that brings me, of course, to the question of security. Because if these records are out there and they're available for anyone to see, how do you control who sees those records?
Yeah, that's an excellent question, and perhaps it's one of the questions that's on most everyone's mind right now. There is a number of different safeguards that we put in place. And to oversimplify it just a little bit, we essentially use the same technologies that banking and commerce does, which is an SSL, or a secure method of accessing anything remotely. Anything that anybody accesses off-site has to be encrypted so that the data is protected in that transitory process. On-site, we have just a number of different safeguards, and while the stage 1 requirements for meaningful use, which is what we're doing right now with our computerized physician order entry, they have a specific mandate that requires security. And so the electronic security of the patient's health information is, they have all kind of safeguards around that. But we actually have to step outside of that and think about the entire infrastructure that we have at the hospital, the physical security of the records, there's just a whole host of security. And we do take those very seriously at our hospital. We, in the IT group, we actually contracted out an independent firm to come in and assess the hospital and make sure that we weren't missing anything, that we didn't have security leaks somewhere that would compromise someone's information. It's a daily discussion with us to how can we better secure the information? Is there any leaks? Is there any, for example, a virus or a malware? You know, you can't take those for granted. You know, so we take all those kind of things very seriously with it, and that context goes to the clinics, the hospitals, and to every facet of what we do is the security.
Okay, what I don't quite understand, does everyone at the hospital have access to those records?
No, that's a good question. We have a need to know access, so we set privilege levels based on what someone needs to have access to. So obviously, someone that's in environmental services would not have access to patient records. Someone in the lab would not necessarily need access to a patient's information about their financial component. You know, we have a patient financial services group that would need access to that, but they wouldn't necessarily need access to the results of the labs or something like that.
So they don't have like a clear, just, you know, I can punch this and know everything about you. No. One person doesn't have that.
The doctors obviously.
The doctors would, I'm sure.
Right.
But, you know, I was really thinking more of the general employees.
No, one of our goals, and we work this constantly, but one of our goals is to only allow the individuals within the hospital and clinics that are accessing information to only have the privilege level to access whatever is relevant for their job title.
So you know who's accessing?
Yes, we can. We run audit reports. We do those upon demand. We do it randomly. Yes.
I think all of this medical records is quite fascinating, and it's such a change. And we're going to do a couple more interviews and let you learn some more from Kirby about medical records at Magee General Hospital and the clinic.